can do an ultrasound. So normally we'll see superior mesenteric vein anteriorly and to the right of superior mesenteric artery. If the location of the mesenteric vessels is the opposite, all superior mesenteric veins is located somewhere posteriorly to the artery, then we should suspect malrotation. We can do CT and we can do ultrasound also at the peak of the symptoms, and then we can see what is called whirlpool sign, which is a swelling of the mesenteric vessels seen both in any transversal type of imaging. However, I have to tell that if we are doing CT to a pillows vomiting child, something is wrong with our clinical thinking. So, what else can cause obstruction in an older child, not in a newborn? I'm not going into the foreign bodies, achalasia and appendicitis. We talked about midgut volvulus, so we'll talk a little bit about the list down. Pyloric stenosis. Very frequent, we deal with it day by day. The child quite often is the firstborn boy, and the child presents with dehydration and alkalosis. So if we're seeing 3 months old, weighing 10 kilos, and that's the usual situation when they're sent from emergency room to diagnose pyloric stenosis, we're pretty sure that that's not the case. And ultrasound has sensitivity and specificity of 100%, so that's what we do. Once we were doing GI studies, but that, thank God, changed. So to make the diagnosis, you should see at least 3 millimeters of thickness of pyloric muscle. Many places will say 3.5 millimeters. And what is more important, we shouldn't see the passage of fluid through the pylorus during the scanning. We should just position ourselves over the pylorus and watch it and watch it. And if no fluid goes through, then we are fairly sure that we are dealing with obstruction by pyloric stenosis. However, consider that pyloric stenosis doesn't happen in one day. It's a developing condition. So if today you measure 2.8 or 2.9 millimeters and you bring the kid back tomorrow, then tomorrow you will measure 3.2 or 2 millimeters. And then we saw cases to both sides, both those with developing pyloric stenosis and those with improving thickness of the muscle. Remember that there is one differential that looks a little bit different but may resemble the children that are receiving prostaglandin treatment for cyanotachycardia may have hypertrophic pyloric mucosa and thickened pylorus. So if you're looking at normal pylorus, the muscle is of normal thickness, the fluid goes through. If we're looking at hypertrophic pyloric stenosis, this is the muscle, this is the mucosa, the stomach is distended and filled with fluid, nothing goes through. Additional signs that can help is the cervix sign, which is protruding of the hypertrophic muscle inside the stomach, resembling uterine cervix, and this one, which is squeezed mucosa, that's squeezed by hypertrophic muscle protruding into the lumen of the stomach, resembling a nipple. One more reason for vomiting is hiatal hernia. Mostly happens in children with neurological impairment. They present actually with severe reflux. They may have some blood in their vomiting contents, and then there may be some degree of twist of the stomach inside the hernia sac, like in this child, when we have the stomach rotating along the vertical axis. Inguinal hernia, pretty often in premature babies, especially in boys, could be bilateral, and the presentation clinically could be due to the strangulation. Like in this boy, we can see multiple distended loops, meaning for us low obstruction. We can see several air bubbles consistent with the intestinal loops inside the scrotum on the left, and then when we put the contrast in, then we see sigmoid goes into the scrotum sac with strangulation at the level of the inguinal canal. Well, let's talk a little bit about intussusception. 90% of these are ileochoric. I'm not sure that this is true because we're doing more and more high-resolution ultrasound, and we're seeing more and more ileo intussusceptions. If we're dealing with a child who is a newborn, or with a child who is 4 years of older, we should actively look for a lead point because that's an unusual presentation. Does the plain film help us? Well, I'm not sure. We cannot really exclude intussusception. On plain film, we can see several signs of intussusception. It may be just the mass filling the right abdomen. It may be the mass with air going around it, a secretion sign. And we can see some lateralization of bowel loops, which represents a jejunal loops pulled into the right abdomen by intussusception. We used to do a volume enema for reduction, but we had poor control over the pressure, and if we caused perforation, the barium dragged the fecal contents into the peritoneal cavity, and we had pretty bad cases of peritonitis. These days, in majority of institutions that I know, air reduction will be performed, and the air should be under the pressure of 120 millimeters of hydrargyrum to keep it safe. We actually have this valve that releases all the pressures above 120 millimeters automatically, so we don't have to watch the pressure while we're inflating the balloon. This is from internet because I didn't have such a case. I rarely do it. I do it only when the radiology unit is not functioning. Then this is the hydrostatic reduction under ultrasound guidance, but many people nowadays do it to minimize the exposure to radiation. And what we can see here is the water surrounding intussusception, pushing it into the direction of the ileocecal valve, pushing it through the valves, and water rushing into the ileal loops. Then we know that we opened the intussusception. So, what can we add to the whole topic of intussusception nowadays? So there was a problem for us with more and more ileo-ileal intussusceptions or jejunal ileal intussusceptions that we could see. And the surgeons told us, prove it to me that this is ileo-ileal, that I don't have to touch it. And we went to the literature and couldn't actually find any sign that will be 100% decisive for the matter. So, if you have an ileocolic intussusception, you should perform a reduction. If you're unsuccessful with reduction, you should do an enema. If you have an ileo-ileal intussusception or jejunal ileal intussusception, just watch it. And in the vast majority of the cases, 99.9%, it will reduce spontaneously. So, how do we decide? For the literature, we found that ileocolic intussusception tend to have lymph nodes inside. They also tend to be large in diameter. However, there is a severe overlap between the measurements for both types of intussusception. So we went back and we reviewed 150 cases of intussusception that happened in our institution. And what we found that we can introduce a new measurement parameter, which is called core-to-wall index, measuring the fat mesenteric core inside the lesion to the diameter, to the thickness of the wall. So this is an ileocolic with a lot of mesenteric fat in it and lymph nodes inside. And these are two presentations of ileo-ileal, either without fat at all, and that's not a problem, and in some cases there will be fat, but there will be much of it. And what we found, that actually in 100%, nothing happens 100% in medicine, but this time it happened. The core-to-wall index was more than 1 in ileocolic intussusceptions and less than 1 in small bowel intussusceptions. So we started to look for anatomical reasons. We didn't know why it happens. And we found that there is a very solid anatomical reason for it. At the jejunal and proximal ileal end of the mesentery, fat is located near the root. And the mesentery is translucent without fat near the bowel wall. So if the intussusception happens at this level, no fat will be involved, or almost no fat will be involved. However, at the ileal end, the fat is located near the bowel wall. And therefore, whenever the ileum is participating in intussusception, the fat will be present. When does it help? You know that in many cases we can't tell, well, this is too small, this is probably ileo, and so on. Well, two simple presentations. This is a 10 years old with Hiatal purpura patients. And the intussusception was quite stable for several hours, and it repeated on the next day. And then the lesion is 25 millimeters, which is fairly big. However, no fat is inside. So we felt confident and told our surgeons that we're not touching it. There is no need in enema and no need in surgery. and it resolves spontaneously. This is 3-month-old kid with very small lesion, or relatively small lesion, 17 millimeters. However, all this is fat, it's mesenteric fat. So when we measure it and divide it by the wall, it is 1.4. So we felt confident to say that this is an ileocolic, and it was successfully reduced. And I hope you are not too bored by this high-tech lecture without movies and without animations. Thank you.